Hello, everyone. Today, I'll be presenting a journal club on the paper Dynamic Surface Electromyographic Responses in Chronic Low Back Pain Treated by Traditional Bone Setting and Conventional Physical Therapy. This work is by Ritvanen and colleagues and was published in the Journal of Manipulative and Physiological Therapeutics in 2007. First, a quick evaluation of the literature. The authors did a very thorough job referencing foundational studies on EMG in back pain and the flexion relaxation phenomena. The citations were highly relevant to the research question, focusing directly on surface EMG and chronic low back pain. This paper has also shown its own relevance in the field, having been cited by 121 other publications, which indicates that it has made some significant impact. Now, let's move to our background and set a bit the stage. This study focuses on chronic low back pain, or CLBP, a major cause of disability, often linked to poor muscle function. In a healthy back, the erector spinae muscles, as we can see over here, become electrically silent when you bend over completely. This is called the flexion relaxation phenomenon, or FRP, as you can see in the top EMG trace. There's a quiet period during full flexion. However, many CLBP patients lose this ability and their muscles stay active, as shown in the bottom trace, where you can see some EMG activity during full flexion. This indicates abnormal neuromuscular control, and it leads for two main research questions. First question, are there differences in EMG activity after treatment with traditional bone setting versus standard physical therapy? And also, is there a link between these objective EMG metrics and a patient's reported back pain level? Let's discover these two questions. So, starting with the study design and the subjects, we're talking about a prospective clinical trial. And as you can see from the flowchart, they started with 150 enrollments, and after exclusions, they ended up randomizing 70 different patients. Now, after some uh, lost to follow-up patients, they ended up doing the final analysis on 61 patients with non-specific chronic low back pain. Inclusion criteria were in age between 20 and 60 with functionally limiting back pain for over 6 months. Key exclusions were prior back surgery or pregnancy, but also for the EMG study, they excluded patients with thick adipose tissue over their lower back, which, as you may imagine, can interfere with the EMG signal. So now moving to our study design and talking more about the procedure. Patients were randomized in two groups using a closed envelope system. They each received 5 treatment sessions over 2 months. A critical point is that the final outcome measurements were taken 1 month after the last treatment session, meaning that there could have been some change during that 1 month refractory period. Ethically, the study was solid, with approval from the university's ethics committee and written informed consent from all patients. The study has some clear strengths, as we can see. The randomization is strong, and of course, blinding the outcome assessor reduces significantly the bias. So, the one potential yellow flag, though, is that the recruitment happened via a newspaper ad, and this may result in a sample that is very limited and too focused, and maybe we can call it convenient. And this can maybe be considered not perfectly representative of all chronic low back pain patients. So now moving to how they collect the data. So they use a surface EMG with bipolar electrodes. They were placed on both the right and left paraspinal muscles at two levels. We're talking about levels L1, L2, and L4, L5. After prepping the skin to get a good signal, they had patients perform a simple dynamic task. First, they had to stand and be relaxed. Then they had to bend fully forward and stay in that eccentric phase, as we call. They had to hold full flexion, and then they had to return to standing. This is very well demonstrated by the figure on the right. This allows measurement of both the eccentric and lower or lowering phase and the concentric or rising phase. So for these positions, the EMG signal was recorded using a bandwidth of 20 to 600 Hz, which is basically a bandpass filter. And the raw signal was actually rectified and averaged to get the root mean square, which is a way to quantify the magnitude of the muscle activity intensity. So now, moving to how they analyze the data. So starting from the RMS data, the researchers calculated two key ratios for this study. One is the flexion relaxation ratio, or FRR, which compares the peak activity during bending to the quiet activity during flexion. So a higher FRR is better. Why? Because it indicates good muscle relaxation. The second ratio that they measured was the extension flexion ratio, or the EFR, which compares the muscle effort where standing up versus bending down. To analyze the data, they used repeated measures ANOVA to compare the groups over time and Pearson's correlation to look for a link between pain and EMG values. Overall, this statistical approach is well suited to our research questions. Here, as we can move to the next slide, we have two key figures from the paper. And here you can see the clear difference that I mentioned earlier. Figure A shows a healthy flexion relaxation phenomenon, or pattern, let's call it, of a patient who's healthy, and you can see silent activity during full flexion, while on the right, figure B shows the persistent muscle activity, which is typical of chronic low back pain patients in this study. So moving to the results, we had three main findings. First, regarding pain and disability, both the bone setting and physical therapy groups showed significant reductions in their pain, disability, and depression scores. There was no significant difference between the two treatments. Both worked very well. Second, looking at the EMG, they found that before treatment, patients had significant left-right asymmetries in muscle activity, which after treatment, these asymmetries disappeared in both groups, indicating that the treatment actually improves the muscle balance. Third finding was kind of surprising. Neither treatment improved the flexion relaxation ratio as it was expected. In fact, the muscles were, in some cases, even more active during the full flexion relaxation, uh, during the full flexion at the month one follow-up. And most importantly, the study found no significant correlation between patients' subjective pain reduction and any of the objective EMG parameters. So this brings us to our discussion. What does this all mean? The authors interpret this to mean that feeling better and having restored neuromuscular function are not the same thing. They propose that the improved muscle symmetry might be the key mechanism through which the therapists provide a certain level of relief. The authors also noted several limitations. The 1 month follow-up may have been too late to see any immediate positive effects on FRP, which may have then disappeared. Also, the patient group was very general, and their initial pain scores were relatively low, so EMG maybe doesn't have the right sensitivity to track any type of correlation. So moving to our significance now, the study is significant for several reasons. First, it challenges the core assumption that the patient's reported pain directly correlates with their underlying neuromuscular function, which is proven to be not right in this study. Second, provides objective evidence that these therapies improve back muscle symmetry, suggesting this is a key mechanism for pain relief. This leads to the idea that muscle symmetry might be a more important biomarker for tracking recovery than flexion relaxation. Finally, a key strength of the paper is that the protocols are detailed and replicable, allowing other researchers to build on these findings in the future. And here are my references for the figures I used in this presentation. Thank you very much for your attention. I hope you learned something today. Thank you.